Okay, everybody, thanks for coming. Although the BME students may feel that it is part of the course anyway. Yes. It's my pleasure to introduce Dr. Brian Blakley. He's a professor at the Department of Otolaryngology at U of M and clinical neurologist. Am I pronouncing it correctly? Yes, close. At HSC. He did his BSc and MD degree at University of Saskatchewan, then finished his residency, then got his PhD at University of Minnesota, still was not tired of studying and researching, went to Toronto and did fellowship there, and came back to our university as a professor and also a clinician. His special interest includes dizziness, vestibular disorder, which is one of the most challenging, in fact, disease within the laryngology department, is to diagnose Meniere's disease, which is quite messy and difficult to diagnose. And he's also, his other interest is in hearing and ear surgery. Actually, Dr. Blakley, it is not within his autobiography, I'm adding to it. He has a very good engineering mind, although he was never officially in biomedical engineering, but in my opinion, he is one of those physicians with engineering minds, so a perfect biomedical engineering field. He has a device for hearing aid. He's not going to talk about that today, but he has instrumented the device, and they're still looking for somebody to continue working on that, and a very interested student maybe. He's also an examiner for the Royal College of Physicians and Surgeons and associate editor for 2 specialty journals. Okay. Please join me to welcome Dr. Blakley.
Thank you. That's a nice introduction. First of all, I'd like to say that it's very nice to have some engineering collaborators who are interested in the ear. Many universities do not. Other universities I've been at do not. Even though the ear is the most interesting organ of the body, it's got lots of nice math and very interesting stuff to go on. Most other organs are kind of boring, you know, heart just pumps a bunch of stuff from the liver and doesn't do much of anything. But the ear, that's a real organ. And so it's nice to have people who are interested in it. I think I'll have to limit my talk mostly to rotational clinical vestibular testing. There's a bunch of other stuff that we could go into, and I made up a first talk and realized it was far too long. And so I'll mention the other stuff a little bit, but mostly focus on rotational testing. Because I think that's also the most interesting for engineers. The ear does a lot of things. Its main job is to detect motion. If the motion is in molecules in the air, of course, we call that hearing. But if it's our own bodies moving, then that's the vestibular sensation or detection of motion. And there, of course, are central connections to the between the ear and the brain. For the vestibular part or the balance part, it goes through a lot of the cerebellum, but there are higher centers. Lower centers going down the spinal cord so you can maintain posture and muscle tone so we don't fall over when we give talks. And higher centers so we can have some cognitive appreciation of what it is when the balance system isn't working, and we call that dizziness. This part of the ear, this is the external canal here, this is the eardrum, and these are the little hearing bones. This part is air contained, that's the middle ear. The part that we're mostly dealing with today is the labyrinth. If I can get this mouse to work, let's see. Here we are. So this is the cochlea, the organ of hearing, which is interesting, but we're not going to deal with today. These are the organs of balance, the semicircular canals, and otolith organs. So the word vestibular, people think it's a strange thing to call balance vestibular, but it has to do with the vestibule, and that's the name of the area in the ear where it is. That's why it's called vestibular. And really what we're trying to do here is detect movement and change of position with respect to gravity. Our sensors are actually linear and angular accelerometers, which is used in many navigation systems, including our own. So for us, the important thing is that the adequate stimulus, as the neurophysiologist would say, the adequate stimulus for the sensors are accelerations, not velocities or positions particularly. And when there is uncertainty as to how fast you're moving or how far or whatever, the brain sends a message to our conscious level saying, well, hang on, I'm not too sure where we are. And that's really what dizziness is, some kind of uncertainty about position and movement. And there are lots and lots and lots of vestibular or balance disorders, most of which are sort of vague and hand-wavy because they're very difficult to interpret someone's symptoms. And in general, it's nice, we like it when we can deal with nice concrete things, you know, a fractured bone or something, good standard treatments. But symptoms like dizziness and pain and anxiety and so forth are very difficult to deal with. They're hard to quantify and hard to measure if you're getting better. And this is a really great challenge, which we really need a lot of help on. So for clinical purposes, that is testing dizzy patients, many questions might arise. Most often the clinicians want to know, want to be able to have some objective test that says, how dizzy are you? Which is really not what the tests do. To what extent are you disabled? In other words, how much does your dizziness limit your function in daily life? Are you able to move around? Can you get out of bed or whatever? Is your dizziness organic, that is due to some organ failure, or is it psychological or anxiety? And in fact, in most people there's a mixture of the two. So trying to sort out the two is the major goal, I think, of vestibular testing. Are you getting better? There are some people who would like to reapply tests many, many times and use that. I don't think that's particularly useful, actually. And generally, we use an indirect method of assessing the vestibular function, namely eye movements. The eyes are closely related to balance function, and we exploit that as much as we can in testing. If you try and pick a target, for example, and move your head quickly, most normal people are able to keep their gaze fixed on that target quite well, and that's due to the vestibular system. For slower movements, we rely more on visual mechanisms of the eyes, but particularly for rapid head movements, we rely strongly on vestibular sensation. So if we stimulate one ear, or even both ears, we get a jerky kind of eye movement called nystagmus, which we use, and it's actually a reflex. I wish we didn't have it as a reflex, because reflexes are prone to alteration of anxiety and other factors which may vary and lead to variability in responses. But that's what we have to do. So this might be one beat of nystagmus. It's a slow phase, which is the part of the nystagmus that is related to the vestibular part. This is a graph of position versus time. So this is the slow phase here, and then there's a quick corrective phase, and that's as a result of an area in the brain called the reticular activating system. So if we use some calculus, we can get the velocity, or even the acceleration, or a variety of other parameters, the beat frequency, how fast these beats are going. This is one beat, but nystagmus really is a repetitive series of beats. In our parlance, I guess the meaning of one beat in nystagmus is sort of like the sound of one hand clapping. It doesn't make sense. You're supposed to have repeated measures. And you'll see a few examples where this is a nice sawtooth pattern that is quite common. I always like to suggest that this pattern where something slowly increases and then goes down is very common in a lot of things like the stock market and predicting stocks. But of course, that's a lot easier than what we're going to talk about today. So of all the parameters that we could study, it's been shown actually that the velocity of the slow phase, that is the slope of this line, is the most reliable, the most useful, and the least variability. So we use that, velocity of eye movements, even though it's sensing acceleration. Now, we can get these eye movements by caloric testing, which is actually the most common and most widely used vestibular test, which I'm not going to talk about too much today. But what I'm showing here is a caloric response. This is the cupula, the semicircular canals. Inside our ears, there are three canals in each ear that are orthogonal to each other. And there is one area, sort of a swelling, which has a cupula in it right here, which this specialized neuroepithelial tissue. When that cupula bends, it causes alteration in firing rates of those nerves. Although some would point out it doesn't bend so much as that pressure, maybe move a little bit. This diagram they show here is wildly exaggerated, this amount of movement. However, when that cupula does move or have pressure, then it gives rise to nystagmus. And the degree of nystagmus, of course, is proportional to the displacement of that cupula. And the displacement of the cupula is proportional to the acceleration of head movements in normal daily life. So that we can say that that cupula is what governs and senses our eye movements in the three different planes of the three canals. However, you can also do this with temperature. This is supposed to illustrate the horizontal canal, which normally sits about 30 degrees from horizontal, and the patient is now laying back so that the horizontal canal is vertical. And that's so that someone can introduce 44-degree temperature water in the ear canal, which stimulates the ear by these convection currents. Although there are some other, perhaps just the warming of the neuroepithelium might cause an increased firing rates as well, and there's other explanations. But at least for a first approximation, we'll call it convection currents. Of course, there is a temperature gradient as the temperature is conducted through the air of the middle ear, the bone, and so forth, as illustrated here. But it results in these eye movements here. These are three sequential. In other words, the end of this one is supposed to link up to the beginning of this one, and the end of this one links up to the beginning of that one. These are eye movements that, after delivery of this warm water stimulus, after a few seconds, the nystagmus builds up. And what we do is measure the velocity of the slow phase, and where that is its maximum, that's the score that we use for testing. These three graphs here show various things. This is the velocity of the slow phase, and this particular one is the frequency, the beat frequency, and this one is the slow phase amplitude. And as you might suspect, this one shows the nicest reliability, lowest variability. This actually is quite consistent across different patients and so forth, and is why we use the slow phase eye velocity as a measure of how the vestibular system is doing. This is how we display those results clinically. This patient, for example, the warm caloric tests are in red, the cold ones are in blue. And the left ear had a greater response than the right ear. This is just in the abnormal range of a percent difference of 27%, or in our lab, a percent difference of 25% or greater is abnormal. And this seems like a strange way to test vestibular function, putting water in people's ears. Non-physiologic, our ears are not supposed to be temperature sensors, and so it makes no sense. However, it's the most widely accepted, most widely used. It does have the advantage of being able to test one ear at a time, and that's nice to do because we're interested in which ear is the sick one. In addition, it's got a lot more data behind it for many years. This was developed, I don't know, in the 60s mostly, so it's been around for a long time, and there's sort of more understanding about what this means, so people in clinical practice accept this more. Even though rotary chair testing, which we'll go on to next, is much more precise, you can deliver a more precise stimulus and measure the eye movement quite precisely. But the rotary chair system or angular accelerations look at the vestibular system kind of as a black box. So you put in an input, here's our rotation, you know what that is, and then you get an output. It doesn't tell you though if there's a problem, is it in the ear or the brain or exactly where, at least I would argue that. Some people argue that and say, oh no, they see little subtleties that might predict the brain, but in general it's hard. However, in each ear we have three canals, and this one is the horizontal canal. We call it horizontal, although it's actually 30 degrees above the horizontal plane. And if we look from the top, we have two other canals, what we call the anterior canal and the posterior canal. These are 45 degrees to the occipitofrontal axis. There's some thoughts that this is nice because there's some redundancy. If you lose one ear, then you can have some information from the other ear, which is nice, or the other sets of canals, rather than having them perfectly vertical and horizontal with respect to our hands. one interesting thing I think about this is that this orthogonal relationship is highly conserved in mammals and in people. If you do CT scans of people or dissect animals, these canals are within 1 degree of 90 degrees. And many things, height, weight, limb length, muscle strength, all these things are quite variable and vary a lot. However, this is one thing that has to be very precise. And that's so that neural hookups can work, and so that so that the trigonometry and the math and calculus can work out, so that we can detect where we are. So these are our sensors of angular acceleration, and of course, when we turn our head in the plane of any one of these canals, or a pair of canals actually, there's a stimulation of the eyes in the direction, considering their plane of rotation, but that's the same plane that the eyes rotate. We also have linear accelerometers or gravity sensors as well, and these are otolith organs called saccioneutrical. These are specialized pieces of neuroepithelium that have little gelatinous matrix on top of them, and calcium carbonate crystals actually. These act as weights. In this gelatinous matrix, the little hair cells stick up, and so that if you bend forward or right or left, these little weights bend down, and according to the vector forces and so forth, how far you bend your head and so forth, that causes the deflection or bending of these cilia, and that affects nerve firing rates. And you can do this experimentally in animals and show that works. In each year, we basically have two linear accelerometers, the sacral here and the utricle, which are sort of at 90 degrees to each other. And in that way, we can tell where gravity is, or if you go up in an elevator, or if we're in some other linear acceleration situation. Now, of course, a problem with all this is that they interact. So the otolith organs can affect the semicircular canals and the output and so forth. So that, for example, if we tilt our head forward, that is an angular acceleration, but it's also a change of direction of gravity. So these things all interact, and that complicates the issue. People try to think up of nice, that was my thesis project, a nice series of, a system of differential equations. For example, one might plug in and say, okay, with this kind of stimulus and that, and turn this, we can predict which, maybe it's the right saccule, the left utricle, and the right posterior canal that wasn't working, and that's nice. Many people have tried that, not really established a very credible system so far, at least that has turned out to be useful. In addition to normal physiological cross-coupling and talking, there are some disorders that are problematic as well and cause mixed up signals. For example, benign positional vertigo, as illustrated here, if you have some of these calcium carbonate crystals from the utricle or sacral, and they get stuck to one of the cupulas, in this case the posterior semicircular canal, then this posterior canal now starts to act as a gravity sensor, so that in particular positions of the head, with respect to gravity, that one canal is going to say, oh, we're turning, and it's going to make a little angular component of the eye movements. And it's thought that these one artist conceptions in this, here's the otolith organs here, and these little crystals can fall down and get stuck. And it makes sense. This is the most dependent of the three cupulae, and that's the by far the most common form of this, so it makes sense. But there are other things that don't. Anyways, we will go into those. Just as an overview, of course, we can get many types of stimulation. Let's say we're going to do rotational stimuli. And basically, when we rotate, we're stimulating the horizontal semicircular canal. People have tried, including myself, have tried stimulating the vertical canals. You can lay people on their sides and twist them around and so forth. And there are many, many, many diabolical vestibular tests that people have dreamt up. Some of which are very interesting, and many of which are sort of just parlor tricks. But I don't know if you've ever been to the Ames research base for NASA, for example. I went there once. It was quite interesting for astronauts. They have various diabolical things, huge little centrifuges, human centrifuges that you go in and you're spinning off axis, and on that there's a little capsule that you're also spinning in as you're going around. And then they can tilt that at any angle they wish. It's amazing we can survive that. But anyways, that's nice, and of course, for space travel, they're very interested in vestibular function because that is one of the major problems that astronauts have. They might do well on land and maybe even do well as a jet pilot. When they get up in outer space, there's some unpredictability regarding who is going to not tolerate that well and who's going to have severe motion sickness, because it's a very different environment that is not exactly possible to duplicate very well on Earth. And so very often you see the space shuttle being landed by the third in command or something, it's because the other two are sick or vomiting at the back, which is kind of interesting. Anyways, we could give many types of stimulus. For example, for this one, this is sinusoidal back and forth stimulus. And as we do this, the cupula, shown at the bottom here, goes back and forth. And here's the acceleration. And if you do your calculus, you come up with the velocity. Generally, the eye movement that we measure follows velocity quite well. But you could give other things, like, say, a constant acceleration for a period of however many seconds, to maybe starting from 0 up to some new velocity. And that has a increasing nystagmus up to some value, and then decreasing. And this can be measured with a time constant, as I think you're familiar with the electrical world. And there's also a so-called impulse, which perhaps is not good, like an electrical impulse or a step is sort of an infinitely short acceleration brief, but these are really sort of acceleration that have to take a finite time. In humans, you can't sort of come from 0 to, say, 100 degrees per second in a millisecond. That would be far too traumatic. So we can do this in our lab. We often do it starting from 0, say, in over 1 second, accelerating to 100 degrees per second. Then I can show you some data from that. But anyway, so you might use the time constant for some of these. And some of these you might be most appropriate to do phase and gain, which I think you're familiar with as well, more familiar than I am. But anyways, we assume that the chair velocity is equal to the head velocity, because we actually strap the head with some Velcro straps to the chair so that it's, well, it can move a little bit, but it's not perfect arrangement, but it's pretty good. And so the idea is that we assume that the head velocity equals chair velocity. And the eye velocity is shown in the lower trace. As you can see, there's a little bit of a phase lead between the chair velocity, and of course we use the gain, the ratio of the eye velocity over the chair velocity, to quantify the system in addition to phase. And the asymmetry, how much is a DC shift, if you will. So this is one model of the vestibular-ocular reflex, which is the reflex we're talking about. And basically there is the deflection of the cupula, so-called canal signal, which goes along and is delivered to the extraocular muscles, which is nice. But there's also a loop here that goes back to the brain called velocity storage. And this is the observation that the brain can take that signal and actually enhance it, prolong the response. And then it sums, comes back and sums here, so that actually the eye movement that we see is much longer than the time constant which one might predict if you just look at the cupula deflecting, which bounces back in a half a second or a second or something, and yet the eye movement response is much longer because of this velocity storage. I'm not sure if I like that name. That's what it's called. I don't know how we store velocity, but that's another issue. So this is a Bode plot that makes some sense to me. This is the gain and the phase, and this might be considered the operating range of the vestibular-ocular reflex, vestibular system. I always like to think that changes are going to if you have pathology, the changes are going to occur at the corner frequencies, which is kind of like 0.1 hertz here. It would also occur here, but we can't really test very well at 10 hertz. That's quite violent for humans, and generally we can't really test much above 1 hertz, causing traumatic brain injury. So we're left with the lower frequencies. This is the phase, of course, shown here. It's so where it's flattish is the operating range. It is true we use our vestibular system at a little higher frequencies than visual systems. In fact, it's a nice little parlor trick to kind of show people, if you take a book and you read it, put it in front of you, wiggle it back and forth, your head is still, so you're trying to follow with visual mechanisms. It doesn't work very well as you get quite fast, but if you hold the book still and use vestibular mechanisms, you can shake your head quite quickly, rapidly, high frequency, and still maintain gaze quite well, which is handy if you're trying to read a book on the bus or something. But that's supposed to illustrate that the vestibular sensors are sensitive up to higher frequencies than the visual ones. Anyways, this is our system in health sciences, which we've had now for a little over a year. This is the chair that the subject sits in, and these little straps here are hooked up to these goggles. The chair, of course, rotates, and back here is a computer controller, which controls the rotation of the chair. The subject wears these goggles. They have infrared cameras in both sides, of both eyes, so the subject can be in the light like this and can see, or can be in the dark. And this is nice, and actually the preferred way of testing most types of tests, so there's no feedback, so there's an open loop system, so the patient cannot suppress the nystagmus or the eye movements. And we generally do them upright, which is not awfully comfortable, but we don't want to have them off axis. If you're rotating right on the axis, then there's no minimal linear acceleration and so forth. However, when they put the goggles on, we can actually see them in real time. So here's a subject wearing the goggles. She's in darkness, but we can see her eyes quite well. There's these little crosshairs that the software uses to pick up the pupil. And if the subject is not wearing mascara and doesn't have any dark things around their eyes, it works quite well. But sometimes there are, artifacts because it's difficult for the subject to pick this up. And this is for the computer to pick up the pupil. But this is a nice, non-invasive way of measuring eye movements. In the old days, we used to put electrodes in the skin and so forth. Those are kind of low gain and subject to a lot of noise and much more difficult. And this is a much nicer, more sophisticated way of doing it. We can see there are several traces here. You can see the right and left eye separately, and for horizontal and vertical eye movements. What would be nice is if we can get rotational eye movements, get three-dimensional movements, and they're working on that actually. They have some thoughts about that, but that's a little more problematic because they'd have to pick up features on the iris that are problematic or something. But anyway, some days you might, that'd be nice. Then you can get those systems of differential equations and so forth, and accelerations, and maybe figure out some more disorders. So this is an example that we might see. This particular one is done at 1 Hertz, and this channel shows the gain. In all of these, the gray area is abnormal, at least what the company calls abnormal. The white area is supposed to be the normal range. And this is the phase, and even though the literature kind of uses both, I think the gain is much more important and much more telling. Phase, I think the computer has a tough time picking. It's looking for the zero crossing, and with these small responses, you can see there could shift either way quite easily. So I find there's a lot more variability in the phase than there is for the gain. And of course, the computer for this is superimposed. I think we have 4 cycles here, 4 sinusoids, but it's superimposed them all on each other. These little blue things here, these little blue things here, each one of those represents a mean of nystagmus. So those are the data that the computer is trying to fit to the sinusoid, and it gives us the phase and gain. And this particular one is just showing the 1 Hertz, and that's why this is green, but the other frequencies are shown here. This particular person has kind of low responses here, low gains. In spite of that, the phase is nice. It's nice in the white range. Kind of illustrating why I like gain as a reliable indicator much more than phase. And you get some things like this, or some bad recordings. This is due to artifacts. Sometimes the computer has a tough time picking up the pupil, so there's some artifacts and so forth. Although, even so, it looks like it might have done not too bad a job of fitting the data. This is a nice clean record, making it easy. And this is the so-called step stimulus. And I put step in quotation marks because it's actually, I would call it a ramp stimulus, where we start at 0 and accelerate to 100 degrees per second over 1 second. We can measure this with the gain, that is what is the ratio of the maximum slow phase eye velocity over the chair velocity, which in this context is always 100. So that, for example, this green thing is showing that this is the one that we're showing here, so it's got a gain of 0.36. So this must be 36 degrees per second. And then it measures the time constant here at 12 seconds. And that's nice. So the company's trying to tell me that for the other direction, the time constant was too short. And I had great confidence that the time constant would be a much better measure. I've never really been convinced of that actually clinically, which is another story, which would be nice to research more if anybody's interested. But there are some troubles. For example, the computer might pick this and pick this as the time constant for this particular tracing. I didn't really like that. So is that right or is this right? All I did for the same two tracing is just move this. You can click on this to move it until it looked a lot nicer. And that's because there are artifacts and difficulties in fitting all these data functions. But in these, each one of these green dots is a slow phase velocity, which you try to fit. So, how do we apply this? Well, one disorder is benign position vertigo. This is a disease that adds an angular component to the eye signal with respect to when the head changes with respect to gravity. So clinically, we test this with the Hall-Pike test. We start with the patient upright like this, and then lean them back so their head is over the edge. And you notice that this head is roughly 45 degrees sagittal plane, so that we're trying to stimulate the posterior semicircular canal in its maximum plane, so it should be vertical in that position. And then, of course, you do it on the other side. And this is a disorder characterized by people come in and the symptoms are spinning episodes of vertigo lasting less than a minute usually, provoked by such activities as rolling over in bed or looking up on a shelf or bending over to tie your shoes or something like some change of gravity like that. These are short and they usually occur roughly every day or similar episodes of that or similar frequency of that. Or not at all. In other words, they don't happen once a month and that's it, unlike some other vestibular disorders. So it's present and quite frequent or not at all usually. And it's quite a characteristic history. And this is our test that we prove it. In fact, if you have these characteristic eye movements and in their diagnostic, you have the disorder, whether or not you have 10 tumors and 6 strokes. It's one of the very few things we can be quite definite about in the vestibular world. So this might be a subject with that disorder. And this is the Hall-Pike test for recording. So the first 5 seconds or so, the patient is being moved from the upright position to their head hanging position. And then the eye movements kind of go away for a while, and then they start here, and it goes beat, beat, beat. Now, there's a rotary component to it, and we don't show rotary very well in this. We're showing horizontal and vertical. So we have to infer that there's rotational movement. When this is happening, I can actually see the video and do the analysis in real time as the cursor goes across the screen. I can't show that. I don't have the software that doesn't look up to do that. But I do have this eye tracing in a video here. So we'll show that. I hope it works. Oh, yeah, good. So this is a few rotatory eye movements as the patient goes back to the head hanging position, and then they stop. And after assuming that position, the eyes start to beat again. You can see here this cursor is having a little bit of trouble finding out where the pupil is. So perhaps the right eye is a little bit better. But you can see there's a little rotational movement of the eye. This is quite diagnostic because there's no way we can do this. You can't voluntarily make your eyes do that. You can make them up and down and back and forth if you want, but you can't fake that. You can't move your eyes in that direction. And as time goes by, the funny eye movements are kind of becoming less and less. And while this is going on, the patient is very dizzy, as one might expect when you're getting conflicting messages, and the brain takes a little while to sort out and realize that one posterior canal is sending incorrect information. That's why it lasts a few seconds. If you challenge it, do it again and again, it's not as bad. If you do it again, for example, right away, then the brain can remember that and learn to ignore that incorrect message quickly. Whereas another hour or two later, the brain might have forgotten that, so it would be the patient will be symptomatic again. So this is another type of nystagmus which is different. This one, so there might be a few rotatory beats here as the patient is going back to the head hanging position, but then this is a persisting nystagmus that just goes on and on and on. And this would be held as long as the patient held their eye in that position. So then they're kind of moving back to the head hanging position. And now you should see, except now this cursor's having a little trouble. But anyways, these are oblique line movements actually. They're consistent. There's no rotatory component. And this might be more characteristic of people who have a brain problem. A pure vestibular problem, a pure ear problem is more likely horizontal. These oblique ones are more likely, well, brain or medication. Medication is really the brain because that's how they act. Yes?
So they are in the dark, right?
Pardon me?
This video is taken while they are in the dark.
Well, they're in the...
The patient is in the dark.
Oh yeah, they're in the dark.
Yes,
All
they
this
don't
is going
see
on.
anything.
Yeah, so this is on the computer. Yeah. In fact, that's the advantage of this testing is that if we do it clinically, well, we have to have people open their eyes so we can see them. So that's the only way we can do it when they're just seeing them as a patient in the office. But with this, when in the dark, we can get much more information because we can see the eyes and they can't suppress their nystagmus. So we could go on and do some cases. It's 6:09. Maybe I'll see if there's any questions, and if there aren't, maybe people aren't understand what I'm saying. But there's a few cases here of how we might apply this to a few humans. But I thought I'd maybe stop at this point and see if there's any questions. Does that make sense? Yes.
What's in the previous video? Can you go to the previous? Because if it was dark, then the pupil should be much bigger. So in visuals, that was is the tumor, or this is to be a stroke, right?
Actually, yes, this might be important. This patient's in the dark, so the pupils dilate, which we all know. But you're right. This next one. Yeah, but these are smaller. These aren't really real small, but pinpoint pupils, for example, might be indicative of certain drugs, narcotics particularly. This software has an option, which I don't bother with, but you can actually use that to measure and estimate the size of the pupil, pupillometry. And then people have normal values, how you're supposed to, how much and how little it's supposed to constrict when you let the light in and not in. And the allegation is that you can use this to see if patients are taking drugs or narcotics. And that's nice. I haven't bothered with that. I'm not sure if I have great confidence in that. I'm not sure if I would accuse someone of taking drugs. But this is thought to be an objective test for certain narcotics and other psychoactive drugs. But yeah, you're right. It's most people though they have quite large pupils because they're in the dark. But every now and again, I find it interesting. There's somebody who has very small pupils. I always wonder if they're on drugs. We ask everybody who comes in if they're on drugs or what they're taking and so forth. And actually we ask them not to take sedatives or psychotropic drugs for 2 days before the test if we can. Other drugs are okay, but people who are dizzy are very often on many drugs, particularly elderly people who are frail and have many diseases might be on different drugs. And it's a challenge to know which drugs should they not be on, which drugs are making them dizzy, how much is the disease, and how much is the drug. And it's difficult. Yeah, it's a good observation. Yes?
What's the orientation of the linear accelerometers that you said, the orientation of them versus the semicircular canals? Are they like orthogonal to that?
Well, the utricle is roughly horizontal, but slopes up a little bit from posterior to what I would call posterior from back to front, let's say. And the saccule is roughly vertical. It's off a little bit, but roughly vertical. So they're basically orthogonal with a little tilt up. Whereas the semicircular canals are what we showed before, where they're rotation in planes 30 degrees from horizontal, and then the vertical canals are pretty much vertical, actually, I should say.
So like the semicircular canals are showing the angular acceleration for that axis that is measured by the accelerometer.
Yes. Yes, and they have 3 axes which are perpendicular to each other. So we know if we move our head at various combinations of rotations that the brain can sort all that stuff out, which is quite amazing, really. It does that 24 hours a day, whether we like it or not, and does all this math and all this calculations instantaneously, and then makes decisions. Do we have to stick our hand out, or are we falling, or what? And makes all this makes all these decisions without us knowing about it. I find that just amazing that it can do that, and we just sort of take it for granted. So I always like to tell people, you know, you think you can do calculus, but you can, and you're doing it all the time. However, this group can do calculus well, and my other audiences can. Yes?
So for other diseases, people may have this nystagmus as well, right? Probably other diseases like their neurological pathways to brain,
Yes.
from different organs, or so. Are those nystagmuses are those having different type of pattern or something?
Yes, that's a good question. There are some, actually very few patterns which are very highly specific. Most of them are just like, they would look like this one. They are, say, horizontal, vestibular, like an ear problem, has this persisting horizontal nystagmus. Central nervous system problems tend to have these oblique ones. Of course, many problems have no nystagmus. But in general, for vestibular testing, we find a deficit, meaning hypofunction. It doesn't work as well as it should, so there's a decreased response or nystagmus, but it's relatively non-specific. For example, Meniere's disease, which you're interested in, may be normal. We have normal vestibular testing, even though it's a vestibular disorder. Attacks of spinning vertigo that are really quite upsetting, nausea, vomiting, and hearing loss in one ear. But those patients may have normal testing, or they may have reduced function on that one side. Reduced function means reduced on the caloric testing, or reduced amplitude. On rotational chair testing, that will be less sensitive actually, but they might have reduced gains. That's what I mean by rotational testing looks at the system as a black box, without very much ability to tell whether it's the right ear or the left ear. Still, though, that has value, I think. I think that abnormal rotational chair testing is a good predictor as to how bad your disability is. For example, if you have abnormal caloric testing but normal rotational testing, you're not as badly off as the people who have bad caloric tests and bad rotational tests. So it is somewhat valuable, and people very often, sometimes there are legal issues, and am I disabled really, and because dizziness is so hard to evaluate, people sometimes get written off as kooks. And one of the values of these tests is we can say, maybe you are anxious, maybe you do have some anxiety, which a lot of people do. However, you also have an organic basis for your symptoms, which is very nice to be able to tell. And disability payments and all sorts of other things hinge a lot of objectification, let's say, of symptoms. If you come in and say, gee, I've got pain, they may say, oh, that's too bad, and there's no other source for it, there's no explanation. After a while, someone's going to stop believing you, and they're not going to, disability companies are not going to give you payments just based on your story without some objective evidence supporting it. Yes?
There's a slide where you're showing eye velocity next to chair velocity.
Yes.
And in that slide, the eye velocity has a phase loop.
Was that that black one?
I think there was only one slide where the velocities were side by side.
Let's see. So which one do you mean?
There's two sinusoidals.
This one?
That one, yes.
Yeah, this is, so this is the chair velocity here, and this is the eye velocity, yes.
So the eye velocity is showing you phase G here as opposed
Yes.
to phase lag.
Yes.
Now, I don't find this very intuitive,
Right?
and I'm assuming this is happening physiologically.
Yes.
So if it is happening physiologically, where is it happening? Is it happening in the vestibular periphery, brainstem, or in the eyes?
So these measurements, of course, are steady state, and in sinusoidal steady state, not with the first half sine wave, let's say. And it is sort of counterintuitive. How could the response lead the stimulus? That makes no sense. And I like to think of it as, the way phase is defined. If you lag more than 180 degrees, then you're called a lead. And that's really what I interpret as happening. However, you could also say, let's go to this one. These ones here. Anyways, there's one that shows that the maybe more where it is, but there's one of these ones here which show that this phase thing that we're showing here is eye velocity. However, it more closely parallels the acceleration, which is what it's actually sensing, and so it may be a differentiation kind of issue. But it is strange that it has a phase lead, and in fact, if the phase lead increases, in other words, the time constant is shorter in pathology, which sort of makes some sense, I guess. If you have a long time constant that's healthy, that's good. So if you're sick, if your ear is sick, then the time constant is shorter. Okay, that makes some sense. But if you sit back and think of that again, you might say, well, what good is it? What good does it have a long time constant? Why do you want those eye movements to go on for 10, 12 seconds? What good does that do us? And that's a little bit up in the air, even though there are theories. But that's the normal situation, is have a nice long time constant. The pathology is short with the phase such that it moves back. It never really becomes a phase lag, I guess. Well, could be, I suppose, if not bad enough. But that's unusual. And when I see that, actually, that's more likely artifact due to the fact that the gain is so low that the computer can't fit the function very well. But you're right, it's very strange, but that's the way we're built. When I give this similar talk to clinical audiences and talk about a phase lead and describe what I haven't described the phase is, because I'm sure you know that better than I do, but when I describe that to clinical audiences, they just say, what on earth, how can the response come before the stimulus? That makes no sense. But this is at steady state. So, should I do one case maybe? I don't know, just for fun.
Do you have our results?
Pardon me?
Do you have the results of us who were your subjects?
Yeah, there were some subjects in the room here, yes.
If you need subjects, they are all volunteers.
Well,
It's a
you
cool
could
experiment,
volunteer
guys.
because I'm still interested in getting some normals. I think I might have collected the largest series of normals so far, but that's one of the problems of this stuff, is that people, like the company has a few normals, but I think it's like 20. I think I now have 30. We do need a few more younger people, though, for some reason. I want to get a nice age range of adults. We're not too interested in children, but adults, say from 20 to 90 years of age. And we, just because of recruiting friends and so forth, they're a little, tend to be on the older side. Yeah, if you're interested, it's kind of fun, I think, anyways. You go in this chair, you spin around. And it's kind of a disorienting, kind of strange experience. So anyways, so this first one is a woman with Meniere's disease, but she complains of imbalance. Meniere's disease has episodes of spinning. Very often they have imbalance and wobbliness in addition. She has a right-sided hearing loss, which you are supposed to have if you have Meniere's disease. She takes a drug called hydrochlorothiazide, which is often used for treating it. It helps sodium potassium metabolism in the inner ear, which is thought to be the cause, and so forth. And takes a low-salt diet. Oh, that's on the bottom again. So recently, she said, when this was done, this is a while ago now, she had 2 episodes of spinning. The last one was about 3 months ago, and some minor ones. And she feels tired. And this relates to what I was mentioning before, the connections to the spinal cord and the other connections. Most people who are dizzy feel kind of tired and draggy. That's because their spinal muscle tone is not very good, not very strong. They feel kind of weak. And in general, being dizzy takes mental energy away from you, and you don't feel good. So anyway, so the question in this person was, is her dizziness now due to Meniere's disease or something else? Because she has one disorder. So she had a rotary chair test, and as you can see here, this is 1 hertz. For each one of these frequencies, the 5 frequencies that I sampled, there's a similar plot, but I just show the 1 hertz because it has all 5 phase and gains on it. It takes too much time to go through each one. But anyways, there's a nice, quite a clean signal, so I believe this. And here's the gain at the highest frequency. And very often the highest frequency is normal, but our other ones are very abnormal. And the phase is kind of borderline here, not too bad. But that's kind of why I don't place that slot in phase. To me, this is a very abnormal trace. So this person is, the vestibular system is not working well. Usually a unilateral that is a deficit on one side would not give this bad a result. These are her caloric tests. And she has a big weakness. Her right ear is a lot weaker than her left. However, for me, the major thing is this here, the total eye speed. If you sum up all these 4 responses, it's only 18. And in our lab, less than 50 is abnormal, based on some normal values. Even though the literature might say 30, those are based on old norms with people with surface electrodes, and people have not really redone the normal values with video technology, which I have to publish actually now that I think about it, because we did this, we were able to do this in an old system that we had before you threw it out, where you do surface electrodes and the goggles at the same time. So we were able to identify the same beats of nystagmus and found that there was a much greater amplitude in the video goggles, so we adjusted our normal values for the sum of the 4 calorics. Now, we don't have to adjust them for the percentage difference because that's a percent and that's relative, so that doesn't change. However, this is a significant problem. These are strong stimuli, actually. Most people in this room would have responses for each ear in the 20, 30, 40 degrees per second per ear. So when you do all 4 of them, it should be 4 times that. So this is a significant disability for her. But also on our MRI scan, if you see these little white blotchy things here, these are not nice. These are lacunar infarcts. And I think these subtle sort of minor abnormalities, which are quite common actually as you get older, I think they are often responsible for dizziness. I did a little study with a radiologist once in Detroit. There was a resident who got a bunch of MRI scans of patients and a bunch of dizziness people have been tested. And I graded their dizziness, the radiologist graded their MRIs, and we found a correlation. We tried to publish it, but they said, well, it's kind of a common thing, and it's hard to say. So it's hard to prove, but I think so. These are little areas where there's not quite enough blood supply to the brain, and for vestibular function to work well, you have to have a lot of neural real estate that's working perfectly well to make all those calculations and send out information to the extraocular muscles, and the brainstem, the occipital area where the eyes governs the eyes. All the rest of the brain have to work well. So one of the things that happens when you're sick is you get dizzy because one of those systems or part doesn't work so well. So if you're on sedatives, for example, or too much alcohol, one of the things you feel is dizziness because there's some slowness, some of the nerves just aren't quite working as well as they could be. And I think the same kind of thing happens in sort of non-specific brain abnormalities. A couple of weeks ago we had a talk about Alzheimer's disease, and I actually shouldn't bring up the exceptions, but I find it very strange that not very many Alzheimer's disease come to the dizzy clinic, which is kind of interesting and odd. I'm not sure why that is, but most other diseases, even if you have pneumonia, you're kind of sick, you don't feel well, one of the first symptoms is dizziness. Dizziness is one of the most common reasons why people see a physician, and we understand it very poorly. In fact, doctors don't like dizziness because it's so poorly understood. We like things we understand. Yes?
I can make a comment. Quite often, we have had 10 Alzheimer's patients. They don't complain of dizziness, but when we test their vestibular system, they have a very poor vestibular system.
Yeah.
By test, I test them only on the sponge.
Yeah. I've often wondered about why don't
Because
Alzheimer's
their
patients...
main problem is bigger than this dizziness, so they don't come to dizziness.
No, but it's fine. Yeah, but you're right, they have terrible brain function. So anyways, for this person, they have Meniere's disease, which is too bad, but they also have reduced caloric responses bilaterally, which is a significant disability, actually. So I think the testing is helpful in quantifying that. MRI scan easily recruiter infarcts, but you could say, oh, that's just a result of aging. Although I think she was only 54, so she's not, doesn't have that bad a case of aging. But anyways, maybe I should stop there if there's any questions or thoughts, or a few more of these. Yes?
Question. Do you use caloric stimulation for treatment at all?
No, the question, do we use caloric stimulation for treatment? No, we had a research study doing that once. It was for traumatic brain injury people, and that was the idea. We were going to stimulate them, and we just did a few patients, and then the grant kind of got, the person left, and the grant kind of fizzled and so forth. But it's a good thought, actually, because it's a powerful stimulus. We don't actually use it for therapy, though. But
I know that, in fact, I've seen a group who have done it for treatment of two cases, two types of disorders. One was for phantom pain, and the other one for treatment of bipolar disorder at their maniac phase. And they, in both cases, they were reporting that they saw significant improvement. To me, it seems that we are resetting the brain by caloric stimulation. But would it be effective for dizziness? That's why I'm wondering.
People have tried it for dizziness without much success, but I'm not sure why it would work for phantom pain. But it is a thought. I thought it might work for the traumatic brain injury people. But we usually believe that if you can stimulate the brain and use it, that it doesn't deteriorate as much. That sounds good, but it hasn't been, it is not a popular thing, let's say. Maybe because it's quite upsetting if you have caloric tests. We do them last, come in for all these testing. Well, if you volunteered, we wouldn't do the caloric test because we have enough data on that. But in patients, we do them last because they're the most upsetting, even though they're also the most useful. Particularly in some centers, they use ice calorics. So you take ice water and you irrigate the ears with that, which is very upsetting and it's sort of painful, as a matter of fact. It's a powerful stimulus. We sometimes do that in our lab if there's no response and we want to make sure that the water got there. We just want to confirm it with ice, which is not very nice to do to someone routinely, let's say. But if you're in a center where they don't have, we have nice calibrated equipment and so forth, it's very nice. But some people just in their office just say, oh, let's see if you're dizzy. We'll take some ice, put it in your wad, put it in a syringe and stick it in your ear, and time the nystagmus with a watch, which is a more crude test of vestibular function. But that's what some places do.
I personally found it quite pleasant. I was subject for the group,
Oh, yeah?
and received the ice caloric stimulation, and I felt very pleasant type of dizziness.
Yes.
Float.
I've had this test several times. Of course, we calibrate equipment, so I've had it many times, and I don't find it too bad, actually. There are some patients, though, who complain about it and say, that's set off my dizziness, and I was dizzy for a week afterwards. And actually, the way I interpret that is a good indicator that there's a strong psychological component to the dizziness. Because clearly the temperature is gone after a minute or two. There's a temperature difference. In addition, the temperatures we're using are not fantastic. They're only 7 degrees above and below body temperature. And if you go swimming, you get much greater extremes of temperature. Of course, you're stimulating both ears symmetrically, and maybe the water didn't get all the way down the ear canal. But still, there should be a lot more people who swim who get really, really dizzy than we observe. So when we see people who say, oh, it was terrible and I was nauseous and vomiting for a week, I think there is an anxiety component. However, we tend to call too many things anxiety. Anxiety does happen, but I may find out someday that there's some neurochemical pathway that we don't know about today that is responsible for that. And I think maybe there are some people who have something that we don't understand